Hi, everybody. We are so happy to receive in your webinar my big friend, Thomas Luebers. He is a chief of neurosurgical department of Clinical Lear in Germany. He and Davi were and are my mentor in endoscopic surgery. And I'm so happy with this day because Davi, Thomas, and my best friend, Marco Moscatelli, together in a webinar. It's a great moment for my life. So Thomas, you can start your lecture and talking about the King's degree endoscope from Storz company.
Dear Marcus and David, thank you for this interesting invitation. I think COVID makes it possible, unfortunately, and I would prefer to sit with you in a congress hall and after that having a beer and a wine. But anyway, we have to make the best about what happens now in the world. And your motto is Spine and Wine, and you asked me to introduce a German wine. I think that we don't have good red wines in Germany, but that's just a question of how you feel about that. But I shared for tonight a white wine. It's coming from a chateau in Germany. It's called Simon. That's a German Riesling. Maybe I don't know if you can see that. No, you can't proper see it, I think. Yeah, that's a Simon. That's a Riesling. I think that one of the best grapes we have in Germany, and we have some very good white wines awarded coming with this Riesling. And this Riesling's coming from Mosel. Well, Mosel is a river in Germany, and I want to give you a short introduction about the landscape we have with that. You see the map in Germany. You can see everybody. You can see that. Yeah, you see the map in Germany. So what I want to go with you today is right now here. It's a region in the southwest of Germany. It's called Pfalz. And if you see that, if you come more and more, you see that river here. It's called the Mosel. And we have two main cities here. One is here. I'm coming back to that city, and the other one is Koblenz. And the border to Luxembourg is built by this Mosel river. But you can hear me? Marcus, everything's fine? You can hear me?
Yes.
Yeah, okay. So just a little bit, there's a sign here that my internet is unstable a little bit. But anyway, I hope that you can see it. This is the middle part of the Mosel, and the wine or what I'm drinking tonight is coming from that small region here. It's called Lößnich, and this is a chateau we have, and there are some very beautiful small cities across this river. And as I said, this is the Chateau Simon, where you can get this wine. It is a dry Riesling, not very heavy. It has about 12% of alcohol, and the company, the Weingut, says that that's an everyday wine. I don't drink white wine every day, but it is not so heavy. It's not not drunken. So you can have 2 or 3 glasses. Should be no problem. So as you can see at the Mosel, we have many slopes here of the river, and you have the small hills and this wine rocks here, and the stocks of wine here, as you can see. And this is typical for this region. And if you come to this Mosel region, you will see old buildings like these old castles here all across the river, and you see the small hills where you have all these wine stocks. And coming back to the first city, I said that's Trier, and this is the so-called Porta Nigra. I don't know if you've ever been in Trier, but Porta Nigra, of course, is coming from the Romans. It's a Roman building. It was built 170 years after birth of Jesus. And of course, the Romans bring the white wine to Germany. And if you go across the river up to Koblenz, we have some very old, nice houses here, middle-aged houses. For example, this Bernkastel, that's downtown. It's the old town we have. And finally, the Mosel goes into the Rhine. And this confluence of these both rivers is called the German Corner. It's very, it's one of the most important spots we have in Germany. And this is a monument here. And as you can see here, this is one of the most important persons of the German history. That's Kaiser Wilhelm I. So this is a German corner in Koblenz. So this was a short trip from Trier to Koblenz. And in the middle, we got this winery of the Mosel wine, the Simon dry white wine, which is a light wine, but it's very tasty. So this was a short excursus to our German white wines, and I'm coming back to the second part of the webinar. It's talking about foraminal and extraforaminal disc herniation, and thanks again to David and Marcus for inviting me. This is a special field, and the history began more than 20 years ago when I went to Tony Young, and I asked him, Tony, I'm a neurosurgeon, we have problems to operate on foraminal and extraforaminal disc herniation. Are you able to show me exciting nerve root? And he tried to do, and he was not able, and it was very hard working on it to improve my skill to deal with these big problems we are still faced today. And today I did a second or third recurrence foraminal disc herniation with some scar tissue inside, but I could remove the big fragment out of the foramen very easily with my scope. So what is the particular aspect of these foraminal and extraforaminal disc herniations? Coming back to some special areas we have in the spine is the so-called hidden zone. So it's a part of the foraminal zone, but it goes lateral, that means extraforaminal, and it goes medial too, that means preforaminal. And we talked a lot about that during our courses in Barretos, preforaminal, intra-extraforaminal. But if we have a problem here in that hidden zone, we have a problem with the exciting nerve root. And coming to the next slide here, as you can see here, this is a hidden zone, as you could see in the previous slide, but this was termed by McNabb in 1971. This was the area about, they had to make the diagnosis without CT or MRI, so they only had the myelography. And if you have the contrast here, you don't see what happened here. And nowadays, there's the classification from Bernocchi and Giovanelli in 2007 that they divided this hidden zone in extraforaminal zone, in foraminal and preforaminal zone. And there's a paper from a Korean group that they divided, that they looked after the grade of migration in zone 1 and zone 2. So we have really interesting parts in the hidden zone, and we are faced with different kind of problems, and we can treat all these different locations with different techniques. So I want to give you an overview about that. So what can we do? We can do, this is a traditional classical neurosurgical approach. It's still done today. So this was done by my former chief. You see the foraminal disc herniation here. This is a pre-op X-ray, and you see the big foraminotomy defect here. And what happens is the instability. And look, this is an interesting paper from China, and they were looking after these different types of disc herniation. That means preforaminal, foraminal, and extraforaminal. And they had about, I think that in total 38 patients they treated, but in 26 cases they did it PLIF or TLIF. And this is very interesting because if you ask orthopedic surgeons or even neurosurgeons, if they are faced with these problems, they are doing, many of them are doing it as a fusion procedure. So this is due to the fact that if you come from medial aspects of the spinal canal, you have to resect the facets, you create instability, and this is one of the reasons why you choose this fusion procedure. There are other ways to treat that. I've got a wonderful video from Rodolfo. He did it endoscopically, full endoscopically, the translaminar approach to that cranial migrated preforaminal disc herniation. If you do it in an open way, you have, like, if you follow this publication, you have a high rate of bleeding complications, and identification of exciting nerve root was only possible in 50% of all the cases. So this is a difficult case. This is a difficult kind of surgery. Of course, why not to do it percutaneously, endoscopically? And this is a paper I published in 2013 when we get more and more used to that foraminal and extraforaminal zone, and we improved our knowledge and our skill using some navigational studies. But what we did was we always went into the disc first, then we removed it to the foramen, then we went up cranially, and we could make the identification of the exciting nerve root like here and the disc herniation like here. I did that studies with the YES system, and the YES system has a 25-degree optic, and I thought that it would be better to have a more directly view on the neural structure, on the exciting nerve root. So that's the reason why we developed the spine tip concept with the Storz company. That means that we have an axis optimized system, and the T stands for transforaminal, I for interlaminar, and P for posterolateral was our topic tonight or today. And this is the 15 degrees, which is announced in the topic today. What are the main features of that scope? It's thinner than other scopes, so you can use it for the thoracic spine as well. It's shorter, and the main thing is that you have a 15-degree optic. This is actually it's like a 0-degree optic, and you straight can view in the Kamen triangle and can make your decompression very safe, and you see what is really going on, and you don't have the problem that you look up to the facet if you're working in the safety zone in the Kamen triangle. So this is this is a beginner case. I think it's L4-5 in the foramen. You see the disc herniation here. This is how we start. First we did the puncture, so we're doing the discography, our target point, the center of the disc. We're doing that always the same because the pathology is not only here, it is in the disc as well. So this is in opposite to what for example, Jomex claimed to have this outside-in technique, not to go into the disc, but pathology is also here. Then we are removing our tube and our scope, and we are directly faced with the problem in the foramen, and we can remove. So if you have a more preforaminal situation, a more medial located disc herniation, we choose our orientation. This is possible if we retreat to the foramen. We can go to a more flat or shallow axis, and we can change to a more steep axis if we have a big extraforaminal disc herniation like this orthopedic colleague who came to my hospital to have this kind of surgery. This is very important, and Marcus, I guess this is the same you had in one of the previous webinars talking about your joystick maneuvers to address all the pathologies we have in or outside the foramen. So just let me explain that technique in a short video with a male patient who got a thoracic disc herniation. It's on the lumbar spine, it's the same, but I think we can do it very well on the thoracic problem as well. You see that problem is here in this kyphotic change to the thoracic. You can better see it here. You see the big disc herniation here. And the way how we're always doing on the thoracic spine is that we are measuring our entrance point, that we are have a determination of our puncture area. So just in this case, 6 centimeters from the midline. And then we start the puncture. As you can see here, we want to bring it in the center of the disc. And this was a perfect puncture and position. And then you see that this was a perforation situation. Contrast is rising up and going down, multi-segmental. So, and the amount of disc material is right now in the foramen. So this is a puncture situation. It's a kind of Seldinger technique. So we introduce our guide. Then it's only a short 1 centimeter skin incision. Everybody knows we're already experienced with PLDs or full endoscopic surgeries. And after this incision, we introduce our dilator. So I have to drink. Okay, then we remove the guide and we introduce our dilator in the center of the disc. And then we use a non-bevel tube. I know that there are other techniques presented already, but this is the way how we are doing. You see that green system we are using. It's all color-coded, and we can use this green scope and the green instruments in that case. This is 1-to-1, really that the case, it's no fake. So we went in to the disc, and what we see first, of course, is central disc material, losing material, some sequestration inside, and we remove it like we did a couple of times in our courses in Barretos. So we're going in, using our forceps. We have a continuous irrigation, as you can see here. This is in the central part of the nucleus. I try to remove as much as I can. It's kind of radical nucleotomy. This was the hospital in Stadtlohn. Marcus, you remember? We had some wonderful evenings in the castle there. But first we did some surgery. And very important is that maneuver we described in the paper, that's the so-called foraminal retreat. So this is the edge of the disc, and this is the posterior wall of the cranial vertebra, as you can see here. And we know it from our discography that disc material is right now here. Normally, if you are, what happens is that the disc herniation is coming into your field, and it's simple. If you keep in touch with that posterior wall, then you can use some hooks or other instruments to mobilize these fragments, and you can remove these soft disc herniations. Of course, you have to do before a CT scan just to see that is soft and not calcified, but then you can move these big fragments outside. This is the final check. You see there are still some disc material inside the canal, and then you can use some suction maneuvers also, and you remove the rest of the disc herniation, and finally you got the evidence to prove that everything is decompressed. So I want to show you next a video about a thoracic case, because there is no other way to do it better with that technique than other techniques. So you see that foraminal disc herniation on the thoracic spine as well. So we are going in, even in T6, T7, it is difficult, but you can do it. You can bring your needle in the right position, in the proper position. So, and then it's quite the same. You have, this is, let me say, the Camden triangle on the lumbar spine. This is on the thoracic, but you have a total control about what happened. Nerve root is right now here on the right side with this non-beveled tube. You push away the nerve root and you got all the freedom to make your decompression, to move, to mobilize the fragments, to get this out. And if you do an open approach, it's difficult. If you do a thoracotomy, it's much more invasive. So this is the best way to treat these problems. So coming to study we did from July 2011 to June 2013, we did a foraminal in 83 patients where only exciting nerve root was symptomatic. That means pre-intra-extraforaminal. So we sent a questionnaire to all the patients and the re-answer was about 53%. I don't know how other researchers having 80, 90, 100% of re-answers. So, but this is the quote we had. So in total, we had 18 patients having a foraminal disc, pre-foraminal 13 and extraforaminal 12 patients. So this is VS leg pain because this is the most important complaint of the patient. They have really severe leg pain. And as you can see here, pre-op and post-op and foraminal disc herniation, there was non-recurrence case in that. Pre-foraminal, we have a higher difference from the pre-op situation to the post-op. There was a good clinical result, but we have to treat 3 patients with a recurrence. And extraforaminal disc herniation, we had the rate of recurrence in 2 patients, and that the amount of pain relief was not as big as we had with the pre-foraminal situation. So, and these are the overall clinical results in this retrospective analysis of our cases: excellent, good, fair, like McNabb, and poor. All these recurrences we had, we voted as poor, and most of them we use again the scope. We had in total a recurrence rate of 12%, and then this is according to the literature and to open procedures. There are reports in the literature about 13 or up to 15%, but we had a high rate of neuropathic pain, especially in the patients of suffering from extraforaminal disc herniation. I think that's not the problem with our technique. It's the problem of the disc herniation itself, of the pathology, that there is neuropathic pain still having some painful weeks after the surgery, but normally it should be better after 6 weeks. So if not, we are doing an MRI and looking after an earlier recurrence. So maybe you, Marcus and David, you remember that we tried to introduce a new classification system, which is based on our spine tip experience. So we have A to E classifications. That mean A means central, paracentral, C caudal migration, and all these disc herniations in the hidden zones. We have that B1 here, B2 here, D1, D2, and E1, E2. And that means B1A is a low-grade dislocation, a B dislocation is a high-grade dislocation, and we got in the A classification we can denote it for tonight small, big, and giant disc herniations. But what we have to talk about today is B, D, and E disc herniations. So coming to a case I operated, is B1B. It's a very difficult case because it's quite medially. As you can see, it's cranial migration, B. E is more medially, and B is high-grade dislocation, as you can see here. But if we follow this kind of surgery, so we are going into the disc, you see the problem here, and you see the contrast is going up to the pedicle, to the mid of the pedicle. But when we follow our technique, so we're going in the disc and then we move into the foramen, we have a slight spondylo here. But if you use our hooks or probes or whatever, we can get this far cranial migrate dislocated herniation with our technique. So this is possible. So this is the video I want to show you. First of all, it's very important to make the identification of exiting nerve root. Then we know that I term it a transaxillary disc surgery, and of course we have to use our hooks and instruments. Sometimes I try to go a little bit here with my scope and I have a more direct visualization of the disc herniation. This is difficult cases, of course, it's not a beginner case, but it's possible. This is a B2A. This is a beginner case, as you can see here. So disc herniation is coming here, and it's pre-foraminal. It's more lateral, and as you can see here, it was on the left side. Nerve root is pushed away with our straight tube, and then you can use your hook and you can remove this more medial disc herniation and the fragment out of the preforaminal region here. This is a very, very interesting case I want to show you, because normally it's a caudal migrated disc. It's coming from L3-4, but it's going far down to L4-5. This is L4 here, and you see this is nearly the level of L4-5. So what I decided in this case was I went into L4-5, then I did this foraminal retreat maneuver. I went into the foramen, and as you can see here, this is a clear exposure of exiting nerve root. You see the fragment here using the hooks, and then you got the base of the fragment. And fortunately, in that case, I got this big two, more than 3 or 4 centimeters measuring disc herniations. So excellent clinical results. The pathology was not in L3-4. It came from L3-4, but I went in L4-5, and I got this also. So coming to this foraminal disc herniation, D1, maybe you can remember this new classification. Even L5 is 1. This is simple surgery. You got, as you can see here, I got a very proper position of the needle. Again, this is my goal, to bring it in the center of the disc. I'm here, I remove. When I'm removing, I'm just faced with the disc herniation. When I'm out of the disc herniation is coming inside of my view, and then I can, this was still contained, I can open, perforate it, and then I can remove the disc herniation. This is a D2. Sometimes it's very difficult to make the identification. It's on the right side. As you can see here, this is here, and you see that the nerve root is compressed here. Again, the facet. This is a disc herniation. This is a disc herniation, and the nerve root flattening here is compressed. So this discogram was not clear. This is a good situation for not having a recurrence, because we have a good central structure of the disc, like we have it in younger patients. But we did the same. We went in, follow the track of the fragment. Then we're doing this foraminal retreat maneuver, and look what happened in that case. The disc herniation came into the field of the tube, and it's really simple surgery. And as you can see here, that's why we choose. Maybe I can stop it, or we go back a little bit. Yeah, you can see wonderfully the L3 nerve root here, which it was on L3-4. You see that's a Kamen triangle. We have the whole view. If we have a 25-degree optic, we cut the field here, so you don't see what happened extraforaminal, and you see more of the tube here. This is one of the reasons why we decide to have a more 0-degree optic, and you have a clear control in the Kamen triangle, and you see you can go with your hooks under the nerve, can manipulate, you can mobilize whatever, and after that you are sure that you got a good decompression. So this is one of my last slides. E1, this is a colleague, as I said, the orthopedic colleague, the same going in and then having more steep orientation like you can see here. And look what happened, the disc herniation in the foramen. It's coming into the field. It's not really difficult, L5S1, because if you got a good puncture and if you follow that technique, you're faced with the disc herniation and you had a good decompression. You see the better fragment here. And this was an excellent clinical result. So the last case I want to show you tonight I've treated, I think that now at least 10 patients having the very extreme lateral disc herniation. Extreme means really extreme. And I don't know if you have any experience about that, but as you can see, the disc herniation is lying here. It's really extreme lateral. And the technique is very helpful of this foraminal retreat because this is a disc here on the left side. This is your nerve root. And with your tube, you push away the nerve, and this really difficult to treat disc herniation is coming into the field. And it's easy to remove these big fragments because you push away the nerve more anteriorly, and you have an access to this anterior dislocated disc fragment. As you can see, there is still some remnants here. Again, a clear control of exciting nerve root, which is shows a kind of inflammation here, and with that remaining fragment, you can see it is easy to remove and to make sure your complete decompression. Described by Wolf's company and written, who's coming from the pedicle caudally, and then he moved into the foramen and tried to get out the fragment. So I'm coming to my last slide. This was the conclusion we had with this all described A to E classification. But what we can say today to intra-extra preforaminal disc herniation, we have this all BD and E herniations with a green system with the foraminal. And we had a cohort study which is still in progress, 260 patients, and we sent the questionnaire and we want to confirm the techniques and the clinical results. But what I can say about the preliminary result are pretty reliable, that we have a big benefit in all D and E herniations using this full endoscopic surgical tool. And I think they are superior to all other techniques in terms of time for surgery, pain relief, trauma, and rehabilitation. So I hope it was not too boring. Probably the best was the wine anyway. So
congrats. Thank you very much.
Great presentation, Thomas. Thank you for the wine explanation and the endoscopic surgery explanation. So I will start making a question for you. I stayed with you in Germany, and I understood that we have a philosophy about ring system from the stores. What do you think when you create a green system? What was in your mind when you create? What you are thinking?
Well, as I said, that I did my study and my publication, this foraminal retreat, I did it with the YES system. And YES system has 25 degrees of optic. So it was possible, but it's a quite long scope. And our idea and our concept was to have the best instrument, the best optic, the best tubes for this kind of disc herniation. So we decided to have a more straight way. And as you can see, I was not, I'm not a big fan from using a burr. Open the foramen, So we decided to have a more thinner scope, a more sophisticated surgery, and not to have this bone removal. And this was the idea behind. We want to have the best, the best technique, the best instruments, best optics for this kind of disc herniation. That was the idea behind that.
Okay, Moscatelli, do you have any question?
Yes, I have one question. Firstly, thank you for you accepted our invitation. You are a great name around the world. It's a pleasure to stay with you. And I never use the 0 degrees or the 15 degrees. For this is my question. Okay, I only use the river spine, the endoscope 25 degrees. Like a Professor Anthony Young, that 25 degrees. For me, is easy. I don't have any difficult to find the fragment around the root or the canal, the channel. Okay. I would like to know your opinion in compare the 15 degrees, 0 degrees, and the axis, extraforaminal axis, where you put your needle in the pedicle, in the caudal pedicle, okay, and protect the roots, and you don't go into the disc, inside the disc before the surgery.
That's a technique described by Rutten. I know that he uses pedicular technique, so he's coming from, I don't come from the lower pedicle. I go straight into the disc because I guess that the pathology, if you have an intra, extra, preforaminal, whatever, the pathology starts in the disc.
Okay.
And if you see, if you come from Joymack's philosophy a little bit, they open the foramen, they have the 25 degrees. This is the 25 degree is figured out for treating disc herniation in the spinal canal. Yeah, so I've been many times to congresses and workshops to Joymax and Wolf. The 25 degree is to look up in the spinal canal. And the choice we made was, now we don't want to have this look into the spinal canal with the green system. We want to have a direct look in the foramen. That was the idea behind that. The technique you described, the extrapedicular technique, coming from the lower pedicle, I know that. I've seen that a couple of times in YouTube. I think it would be very, very difficult to treat a case like the last I showed you with this extreme lateral disc herniation. I think there is no way to have a good access to the disc herniation, to the fragment. And what I'm doing with my technique is I'm coming from the disc, which is much more easier. And then I go into the frame and I go in the Kamen triangle. I move away the nerve root. I identify the neural structures, and then I see what happens really with my disc fragment. That's the idea, because 25 is going up to more medially central problems, and 15 is more in the foramen.
Okay, you always goes inside the disc and comes outside and push the fragment.
Yeah,
that's the idea.
Okay.
And I always perform a discography because pathology can change. You see your pathology. This is a kind of guidance you have. Here you see the contrast. Very often you have the disc herniations covered by the contrast, so you know where you have to go. So this is, and last but not least, discography gives you an idea about possible recurrence rates. If you have a good internal structure, you don't have that high rates of recurrence we still have, I guess. And so there are many advantages to do the discography.
Okay, thank you very much, Annie. Thank you for your explanation about the wrestling. I'm drinking the Riesling. This is very good. Thank you very much.
Mosca.
Yeah, Mosel is one of it's a very nice area in Germany, and so my wife and me, we are thinking about spending our summer holidays not in Greece or Italy or whatever. I think it's not possible. I don't know if you can go to the US or whatever, but we want to stay in Germany, and first we want to go to the Mosel region to have a good white wine, hopefully in a good weather with warm and good conditions.
Thank you very much.
Mosca, I think that the main important thing is when Thomas developed the green system with 15 degrees, he is not thinking about the channel. So when you have a scope with 50 degrees, you have a DRV, a direct root visualization. So if you see, you can feel that he used a 0-degree sleeves. Why? Because when he make the retracting maneuver, he can pass through the root without damage, okay? So he entering into the discal space, and he are making a retracting maneuver.
Yes, the difference is this: is inside, outside, and the 25 degrees. I go outside, inside.
Yeah, and the sleeve has 0 degrees.
Yes, I know.
He can
yes.
fight above the nerve root without damage the ganglion.
Yes, good surgeries. Yes.
It's a it's a modification of the inside-out technique from Tony Young. He actually was my teacher about that, and he's using a discoscope. He's staying in the disc. So his inside-out technique means to bring the disc herniation inside the disc and then pull it out.
Okay.
So this is a technique addressing the central, paracentral parts. And
you don't do the discectomy after the remove the work sleeve. You only put the disc and retract the disc.
No, I try to remove as much as I can from central part, because I think that these maneuvers avoids recurrence rates. So I improve more and more. So I'm coming from 15% of disc recurrence rates. So now I think I'm less than 10%, because I try to get out as much as I can. But you can't do it, and that's the problem of this poor transforaminal. If you have this extreme lateral approach, addressing the central, paracentral disc herniations, you can't really have 3/4 of the disc, because you only have the posterior fifth of the disc. So this is one of the big issues about higher recurrence rates in doing this transforaminal. I had 20-25% recurrence rates about that. I improved because I change. I look after my indication. I look after the age of the patients. I look after the degenerated conditions of the disc, and then I make my choice. And if I have any doubt about endoscopical approach, I use my microscope.
Davi, your considerations or questions, please.
First of all, I would like to congratulate Thomas for his presentation, both presentations about the Riesling wine and the foraminal extraforaminal technique. And my first question is regarding the article that he published about the cases that he operated between 2011 and 2013. He reported that he had up to 35% cases of dysesthesia and 11% cases of recurrence. So my question is, did it change during your learning curve, like in the later years, in the last 3 years? Do these rates, they keep the same, or did it decrease? They did keep the same, or did they increase? During your learning curve, did you change something in your technique to reduce the number of dysesthesia patients in the post-operative period or the rates of recurrence? Did you perform anything to reduce these rates?
Honestly, well, I I only have a few cases of dysesthesia after my surgery. I think, and this is a question of learning curve. What I started with that technique in 2000, so I'm doing it nearly 20 years. But I'm still learning, and the 35% of dysesthesia, I think one of the main problems, even if we look at the results, on the literature, are missed fragments. So we still have fragments in compressing the nerve root. And my technique now, my skill is getting better and better. So I reduce my recurrence rates, I reduce my dysesthesia rates, because I have more and more safe decompression. I'm sure what I'm doing. I have the proof. As Marco said, with his joint, with his movement techniques, like a joystick, this is what I'm doing. I check after after the removal of a disc, I check my pre-foraminal, and very often I can mobilize still some fragments. And this probably is the main reason for dysesthesia and intraforaminal disc herniation, remain fragments. I'm getting better and better, of course.
Great, great. I would like to know the opinion of Marcus and Moscatelli. How do they perform their rates of this stage in the postoperative period, and what they do to avoid it?
Davi, I've been using corticosteroids, pregabalin, but we know that dysesthesia can occur 3, 4, or 5 days after the procedure. It's different when the patient awake for the surgery with pain. Dysesthesia can occur 4 or 5 days. So we have a friend that have been using corticosteroids into day 5, day 7, and day 9 with an injection, intramuscular injection, to prevent the dysesthesia. But I think that the dysesthesia, it's regularly it occurs when you make the joystick maneuver, because the ganglion of L5, L4, L3, L2 is inside the foramen. So I think that when Thomas created the green system, he created a thinner scopes with 2.9 work channel to can make the joystick maneuver with less compression of the ganglion. So less compression, less pain after the postoperative. And Luebers, we have a question from a participant here for about dysesthesia too. What's your, Thomas, what's your incidence of dysesthesia? 35% with no awake surgery, yes? All the time you perform the surgeries with general anesthesia, yes?
Yeah, this is almost done in general anesthesia, of course.
Mosca, what's your opinion?
Yeah, I always use my 25 degrees and endoscope, and I decrease my dysesthesias. Use the extraforaminal approach. For this, I asked you about this difference, because I always use, most parts, I use the extraforaminal approach. I see the pedicle. I don't need to drill the facet joint or the SAP, the SAP or whatever. I put my needle in the pedicle. I find the disc, mobilize a little bit the root, and remove the disc. Remove the disc, find the PLL, and remove the disc. I decrease my dysesthesias with this approach, because I never use it inside, outside. I don't know use this side. I learned it the outside, inside. But in the beginning of my career, I put the dilator into the canal, into the foramen, put the work sleeve, remove more fragments, and maybe I compress more the exiting nerve root, the ganglion or the exiting nerve root. For me, the dysesthesia is a lot of manipulation of the exiting nerve root. Only this one, nothing the vascular block, nothing the I don't know.
The compression of the ganglion.
The compression, yeah, only the compression. When I use the extraforaminal approach, I decrease my diseases. But I saw, I have seen the cases is more recidivist in transforaminal approach where the interlaminar approach. What do you think about, Thomas?
You mean that we have higher rates of recurrence?
Yes. I have more recurrence with a transforaminal approach more than the interlaminar approach. Of course, not the extraforaminal disc herniation, but the disc herniation in general.
Well, I tried to point out already that when I have this extreme lateral approach, so we only have an access to the posterior fifth of the disc, and we can use some hooks to have to mobilize the fragments from inside. But we don't go really into the center of the disc, and we are leaving a weak part of the annulus. There is really a cleft in the disc, and this is not a barrier. That's the best way for recurrence. So this is why I'm looking after the indication. The younger, the better. So if I overview teenagers I treated from 13 to 19, about 10, 15 cases. I've never seen a recurrent in that cohort. Yeah. So if you have a patient who's 70-year-old, I try to avoid to do transforaminal access on that patient because they have a high degenerated disc. You're leaving a weak part of the annulus. This is a big way for recurrence. I don't trust all this good result in the literature reporting about 6% or less of recurrence rates. So if you will start with the technique, you will have 20, 30, 40% of recurrence and reoperation rates. That's the truth.
Okay.
We
have some questions.
Can I say something about I would like to go back to the dysesthesia topic, which I believe is one of the most interesting regarding the extraforaminal and foraminal disc herniations. And I say that maybe one of the most difficult punctures that there is in the endoscopic technique is when we have the foraminal and extraforaminal disc herniations. And sometimes it already happened to me that when I had already positioned the tubular retractor of the working sleeve, that I found the nerve root underneath my tube, underneath my working cannula. So many times the exiting root, it comes out from the foramen too close to the superarticular process. So we have little space to introduce our working cannula between the root and the superarticular process. So in these times, those patients, most of them, they will have some dysesthesia in the postoperative period. It's something that is hard, it's difficult to avoid. So what I try every time when I see that the foramen is too close and I may harm the exiting root, is to make a puncture as distal as I can in the foramen, so to avoid it. So, but it's difficult. Sometimes it's quite difficult to lead with the situation, right?
David, can I give a comment on that? Because that's absolutely true, what you say. This is why we have the smaller tubes, the smaller instruments, the smaller scopes, just to avoid, if you have these big instruments from Joymax, for example, you have to open the foramen. You have to ream the outer part of the facet. Otherwise, you will get in conflict with the exiting nerve root. This is one of the reasons why we have a more thinner system for that, to avoid these problems. So we don't want to have a resection of the bone. We don't need it for foraminal and extraforaminal. But if you have big instruments, like the fusions descriptions, posterolateral fusion, endoscopical assisted, they have high rates of neuropathic pain because they introduce so big tubes and instruments and all that. Then you have a really severe mechanical elicitation of the exciting nerve root. That's the problem. So, but the smaller, the better.
Okay, that's the question of Cleanto. In this case, that the disc enters the work channel, is it dangerous? Traumatize the nerve roots? You answer the question of Cleanto. Talk, Davi.
Facundo would like to ask a question. Facundo Vanisli from Argentina.
From IRCAD too.
First, I want to congratulate the Luebers. This is not the first time I see your presentations. This is as excellent as always. I wanted to ask you not about the present of the past of endoscopy, but about the future. I saw some interesting cases today about these herniations, lumbar disc herniations. You presented a case of thoracic disc herniation. We are doing now some stenosis cases, foraminal stenosis, central stenosis. We're doing cervical surgery by a posterior approach. And since you are one of the pioneers and one of the people who contributed to the new technologies like a few years ago, I wanted to ask you about what do you think about the future? Where are we heading with endoscopy? Where are the future pathologies to treat? Are we going to stuck into the degenerative disorders, or we are going to go further, maybe treat oncological patients and maybe some another diseases? What do you think about it?
Well, I think that we still have a big debate, especially in Germany. What is the best way? And 2 years ago, we had a really good, interesting talk during the annual meeting of the neurosurgical department, neurosurgical society. And we had 15 or 20 cases of thoracic disc. And the neurosurgical society is very restrictive about what we are doing. So I probably have the biggest experience as a neurosurgeon in terms of endoscopic surgery. But in my former hospital, I was always in a competitive situation. There was one of my partners, he did an open surgery, and I was doing the endoscopic surgery. And the first years, his results were much better than mine. So we had a kind of competition. And what I found out was that in special kind of disc herniations, it was superior to use an endoscope. For example, thoracic spine, upper lumbar spine, far lateral, recurrence rates on children. This will be the future. So I think that we have in a good spine department, we have to have everything. We have to have a microscope. We have to have the option of arthroplasty, of fusion procedures, of reduction maneuvers, of screws, of whatever, interspinous device. You have to have everything, but you have to choose the best for your patients. And right now I know, and I was in this competitive situation. So once it changed, my former partner, he did an open L2-3, and it was an obese patient, and he got 2 liters blood loss. And I did the same surgery in 20 minutes with 2 cc blood loss. So these are the difference. I did some more calcification disc herniations. I used the burr for that. I'm still learning that now, but this is really big benefit for our patients, because my previous surgeries were the transthoracic way. So I had to open the thoracic cavity, and with all these problems we have associated with the surgery. Coming to other indications, I had one oncological colleague. he sent me all the patients to do an endoscopic assisted biopsy of metastasis, because he said, if I send them to a radiologist, I got a 20% false negative results. So I want to have a big amount of metastasis material. The other thing, that the second best indication for the PLD or percutaneous approach is discitis. I treated many, many patients. I did some tumor removals. I did some sympathetic chain resections. Marcus and David, you've all seen these cases, even on the lumbar spine. There is a high potential still under evaluated, not really discovered. We have to work on it, because there is a high potential in that type of surgery. So there will be, of course, there will be a future for the surgery, there's no doubt. We have to be better and better and to convince.
Okay, thank you.
Thank you.
Thomas, you have a question for Gabriel Bessa. In L5S1 approaches, can you use in the green system endoscope decrease the risk of dysaesthesia?
I don't have, the paper I published was L5S1.
Yeah, I know, but
I know, that is absolutely no problem. L5S1 for transforaminal to get access to medial or centrolateral disc herniation is sometimes difficult. It depends on the height of iliac crest. But in the foramen, there are no restrictions.
But
sometimes if you have a pre-foraminal in the central canal, could be difficult without bone removal. But it is only L5S1. But if you have a foraminal, extraforaminal, I think it's if you're aware, if you know how to puncture L5S1, if you have an extraforaminal, like I showed the slide from the colleague, this is a beginner case. Simple, because the fragment is coming into your tube. Yep.
Mosca, Davi, another question?
There are a lot of questions in the chat. Yeah.
Yeah. Thomas, what do you think about UB, unilateral biportal endoscopy? Do you have any experience about it?
No, I don't have. When I started with this endoscopic surgery, I introduced the scopes and instruments from both sides. I've seen that last year in Mexico there was it's a technique not really convincing me, because there's one technique using the endoscope, and from other the other entrance is to introduce some forceps and other instruments to remove that. I think that it's not really a benefit about that, to use that technique. That's a unilateral biportal technique. That's more, why should we do it? You can use a microscope for that. Yeah. I've seen that. I've seen a live surgery with big problems in a normal disc herniation L4-5, and the surgeon had big problems with that unilateral. So they biportal in one portal, the endoscope, and the other the instruments. There's no benefit in my eyes.
Okay, Davi, some considerations or questions? Davi, are you hearing me?
Yes, now I'm hearing you. No, those are great explanations of Thomas. Regarding the use, there is a question here of one participant. Does he ever try to use the beveled cannula, or he never tried to use it? Does he see any advantage to use it, or Dr. Thomas only uses the round cannula?
The technique we developed is designed for the non-bevel tube. I know this extraforaminal technique is you using the bevel tube. My experience is, if you use a bevel tube, that soft tissue is coming into the open window, and this covers in the nerve root. So identification is difficult. So this is why I choose a non-bevel tube and this technique, because I want to have the clear identification of the exceeding nerve root, and this is possible with this technique. So if you see this, I've seen that a couple of times in YouTube, this extraforaminal technique. It is really, really difficult, and if you try that, you will see. Try to compare. Use the bevel tube with the extraforaminal technique, you will have big problems to make the identification of exceeding nerve root. If you use the green system, if you go into the foramen, if you keep on that technique or on the technical descriptions, you will make your identification, that's sure. I think it's much more easier to use that technique. Bevel tube, soft tissues coming in, makes you disorientated in your field of agitation. So that's, I don't recommend that. That's my experience.
Another question for the participants. Mário Bressan from Brazil. Did you have any concerns in accelerating the degeneration in the L4 and L5 disc? Do you have afraid to create a degeneration in L4 and L5 when you enter into the nucleus?
Yes, of course. We accelerated degeneration. I had a big discussion with my neurosurgical society about doing discography, because this promotes the degeneration as well. There are some studies having that. But the problem is, if I do that, we have already a degenerated condition. But honestly, what I have seen after this removal, it's the same after microsurgical decompression and removal of the disc. You have more and more osteochondrosis situation, disc height decrease, and you have all the problems you have with an open surgery as well. If you don't put any implants in, that's the same.
When I stayed with you, I remember that you performed a microdiscectomy. So when you perform the microdiscectomy, when it's not available to do the endoscopic surgery in your mind?
I rather do it in older patients with severe degenerated conditions. If you have a severe osteochondrosis with lateral stenosis, recessed stenosis, if you have a disc herniation, if you do an open surgery, you have really good results. There is no doubt. If I do, it's a compromise. If I use my endoscope for that, I feel not that safe and sure about the clinical result after that. If I do a micro, I'm sure about my results. I have a radical nucleotomy. I use some curettes. I have a safe decompression that's much more safe compared to to endoscopic procedures if you do it for the transforaminal axis. So older patients, stenosis, I rather like to use a microscope.
Okay. Thomas, my last question. I know that the other guys has another questions, but what's your opinion about foraminoplasty? When you stayed here, you saw when we performed one. What's your opinion about awake and aware foraminoplasty?
The last course or the last two courses we had in Brazil, and I saw you doing the foraminoplasty, I was quite impressed, because I'm not used to do that technique, but I was impressed about your skill and how you do it. And I think we have some good indications for that. For example, I tried to do it, and I did a couple of cases. I use a combination of inside out and outside in, and I did a foraminoplasty in a thoracic case, in a calcified case. So I had to remove, like an actual technique, part of this base of the calcified fragment, but I had to remove facets always. I think we have it is very helpful to do foraminoplasty like you did in some of the cases. It opens the foramen, it gives you more freedom. I think it can help really. Spine tip actually was not designed for foraminoplasty, but it is a good adjunct. It helps us. It gives us more freedom. It gives us more indication for PLD. So sure, it will be the future also. Having a good skill with the burrs and I see Rodolfo. Rodolfo, hello.
Adolfo is here. Adolfo is here.
Yeah, Rodolfo. Maybe I was so proud because in Mexico I was presenting. Maybe you can give a comment on it, Rodolfo. He did an excellent video about translaminar approach with the endoscope, and there was technical a brilliant surgery, and it was technical a brilliant video. So this is really encouraging to see how it goes. Rodolfo, can you give a comment on that? Do you have any more experience about translaminar approach? It was a perfect, absolutely super procedure using a burr, like you do a forminoplasty, but he did a translaminar approach.
Rodolfo, are you?
Can you hear? Can you hear me?
Yes, I hear you.
Okay. Thank you, Thomas. It's a great pleasure to have you here again. I always learning with you. We are very skilled doing this technique, foraminal retraction, and I want to tell you to the participants that this technique is very reproducible, and if you follow all steps you can do yourself. About the translaminar approach, I've been performing interlaminar approach, and translaminar approach is one of the part, but most of the case I use the sublaminar approach. In that particular case that Thomas is talking about, it was because the disc herniation was between the pedicle and the nerve root, and there is no bulging in the disc. So it was just a sequestration, just a free fragment, and my target was just go direct to the fragment. But if I had a link between the fragment and the disc, or a bulging or disc herniation in the level of the disc, probably I would perform maybe a sublaminar approach, not a translaminar approach. But that was a good experience for me. I learned a lot, and I have this weapon to use when I have that specific situation, or I want to perform, for example, a biopsy in that point, or any kind of pathology that I want to read. So, but I'm very impressed with your skill about to get the B1, B2 through the foramen. To the foramen is very nice to see how you get the foramen. And I have a question for you, because sometimes we have patients with disc herniation, and we know that if the patient has a new disc herniation, I mean between 1 month or a little more, and it's different if you have the patient with more than 6 months disc herniation. So do you take into consideration this difference to decide what technique, open or endoscope technique, you use?
Yeah, in case of a far lateral disc herniation, I rather would do an endoscopic procedure again. So this is what I talk to my patients, and I try to say that, or I want to have the same endoscopic surgery also. In case of mediolateral, central, paracentral disc herniation, if I have a recurrence, I rather would do it microsurgically, or sometimes I do an anterior approach, ALIF, disc prosthesis, whatever. But in case of more lateral, far lateral foraminal disc, I would choose primarily the endoscopic approach.
Okay.
Yeah, Professor, I have a question. Marcio Pena did a question, and this is my question for you too. Yeah. In your surgeries, for these cases, do you perform your surgeries with a general or local anesthesia? If general, what situation is general anesthesia indicated? About the anesthesia, is local or general in the transforaminal and the interlaminar approach?
In general, I do for all these cases do a general anesthesia. There are special reasons for that, because we discussed this a lot. If you're a beginner, if you do it in local, the patient feel that you are a beginner. So this will give you a ping pong situation. So you're getting nervous, the patient is getting nervous, you're getting more nervous, the patient is getting more nervous. So you need, for this really challenging and difficult surgery, you need all the best conditions you can have. You need a good team, you need a good C-arm, you need a good staff, you need good instruments, and then you can do the surgery. But I recommend, you can overcome these problems with elicitation or with irritation of exciting nerve root. You need a good puncture, you have to follow all these descriptions, how to introduce the instruments. Then you overcome these problems. We did some navigational studies, we did some neuromonitoring studies. So nowadays, I'm not afraid to hit the excited nerve root because I know how to do the puncture. This is more important than to wait for the response of the patient who's awake and who will have pain if you have a conflict with the excited nerve root. You never will learn the technique.
Yeah, so and the interlaminar approach too, and the local and the sedation.
I think interlaminar you should do it in general, and I know that David, do you always do it in general? Yeah, interlaminar.
Yes. Yeah. I'm performing both in the general anesthesia. I don't use the local anesthesia with sedation for 3 years. I'm using only general anesthesia.
And it's much more comfortable for you and for the patient to do it in general anesthesia. We have to train the beginners to do right puncture, to have a good technique, to know, to demonstrate how to do. Then you will overcome these problems.
Yeah, in my opinion, I never use the local anesthesia. I always use the general anesthesia for the transforaminal approach and the interlaminar approach. I think so about the local anesthesia for the beginning, maybe like you. Both are nervous, the patients and the surgeon. You never do what you need to do when you have a complication. You stop your surgery, the blood put you nervous. The room, there is other persons to see. Maybe you stop, you don't not remove a lot of disc. I think you have more dysesthesia in the general anesthesia maybe, but I don't know. In my case, the extraforaminal approach, I have a increase, but you have more the beginners, but you have more. It's more comfortable for you. You have a security because the block motor. I don't the name in English. The block motor curati. I don't know the name. Stop with 8 minutes. You have a response of the nerve. You have a response of the muscle in the general anesthesia. I think it is.
I have a different view of the anesthesia. I think that interlaminar approach, it's forbidden. Don't do with general anesthesia. But when you have to do a foraminoplasty, it's very important for us to see the response of the patient during the procedure. And when you make the surgery with a awake and aware patient, you can see and you can feel the pain generators. Sometimes during the procedure with awake surgery, the patient talk to us, my pain get out. The patient talk to us about this. So interlaminar approach, I've been performing all the time with general anesthesia. But transforaminal L5S1, I think that's very important to do the surgery with awake surgery, because L5 nerve root has a different way around the foramen, and if the patient is not awake, you can create a damage in ganglion.
Yeah.
So,
one question for you, Marco. Okay. You have a preoccupation about the exiting nerve roots in the transforaminal approach. Your patients, oh, my leg is pain. Okay. Why you don't use in the interlaminar approach the local anesthesia? Because you mobilize a lot of the roots into the canal. You put your scissor, you put your punch. You can do a dysesthesia and local damage to the root, because I have a dysesthesia in the interlaminar approach, less than the transforaminal approach, but I have.
Yes, Mosca. All the time when I'm preparing the surgery, I think that the main important thing during the endoscopic surgery is the planning of the surgery. So I follow and I answer 3 questions before the surgery. What's the root are pain? Where is the compression? What's the best way to make the decompression? So for L5S1 disc herniation with S1 compression, for me, you have to enter interlaminar approach, okay? But you have to remember that S1 ganglion is inside the canal. So when I mobilize the S1 nerve root, I've been mobilizing the ganglion. So yeah, you can create a dysesthesia in postoperative. So if I have L5S1 disc herniation with L5 radiculopathy, for me, you have to enter by...
no, it's okay. It's okay. But it is the anesthesia in the interlaminar approach. What do you... For me, peridural or epidural or Haki anesthesia?
In my hand, L5S1 with L5 radiculopathy, you have to enter in awake surgery, because you can test the patient all the time. So when you try to enter with your dilator, the patient can talk to you, oh, my leg has pain. And you can move your hand and adapt your sleeves to decrease the ganglion compression. So all the time during the procedure with awake surgery, I'm talking with the patient and you can see the pain generators. It's not uncommon. The patient talk to me, oh, my pain get out. So I stop the surgery, okay? So L5S1 central or posterolateral interlaminar, L5S1 with L5 radiculopathy, awake and aware transforaminal approach. This is my rule. I don't know if I'm correct, but I follow these rules to make the surgery. What do you think about it, Thomas?
Yeah, if you're mastered like you, so you're now you got your experience, your skill is getting better and better, then you can do it. But for a beginner, I don't recommend. Is it not a beginner case, L5S1?
Yeah.
Yeah. For a foraminal problem, we are talking tonight about these problems. They have to do L4-5 or L3-4. So this is for mastered cases. So if you've got experience, then you can do. I don't have any problem really. In the last 2 years, I did a couple of surgeries, endoscopic surgeries in local, because patients had some heart problems or COPD or whatever. They can't get any general anesthesia. I never had a problem because they feel that I am really experienced. So every time when I'm doing my step-by-step surgery, they feel I'm experienced. But if you're a beginner, this is a big problem because they feel you are a beginner.
Okay, Davi, what's your opinion about it?
I agree with Thomas and Mosca. because if you have the landmarks, the safe landmarks of safe puncture, so you don't need the local anesthesia. You can perform a very safe puncture and positioning of the working cannula without harming or with a few manipulation or a small manipulation of the exiting route. So I believe that's better for the patient, it's better for the surgical team, and it's better for the anesthesiologist to perform the surgery under general anesthesia, is what I believe. My quality of life improved a lot when I started to perform all my surgeries with the general anesthesia.
Me too.
Moscatelli.
When I was 20 years ago, when I went to Tony Young, I have seen that, and that 2 or 3 years later, I went to Tom Hoagland to Munich, and they needed 2 strong guys to keep the patient on the operation table. So, and even today, one of my fellows went to India, and they did a local surgery, and she said that was a horror trip, a nightmare for the patient. So okay. I follow David. Well, I feel much more better.
Yeah.
But Thomas, when you stayed in Brazil with me, you saw an awake and aware surgery, and you can see that the patient was very comfortable during the procedure.
Yeah, because you're skilled, you're experienced now. You do it.
Yes, of course.
Yes, and the anesthesiology too. I think that the main important during the awake and aware surgery is the anesthesiology. You have to. Yep. He is your partner, not your enemy. Okay.
But if you have an experience, you can do awake, no anesthesia or general anesthesia. But at the beginning or the intermediate surgeon is very difficult. The patients, wow, it's terrible in my opinion, sir. But Thomas, there is a person, August Karama, I don't know the name, but thanks Thomas. I am also using your technique for lateral discs. I have hesitation. Do we really need to enter the nucleus and make the debridements? Maybe this question is like my questions, because for me, when you open a little bit more the annulus, you have more recidives return, and you remove more disc, more nucleus. You put your patient in more degenerative disc. You have these questions. All questions appears for us.
Yeah, well, that's a good question, because there's a technique described by Loy from Switzerland. He's doing the puncture, he's doing discography, but he stopped at the annulus with his tubes. My experience is that I tried a couple of times in my surgeries to stop on the annulus, to bring the tube. It was much more difficult for me to make the identification of the exciting nerve root. You can do it, of course. Stop at the annulus if you don't want to accelerate disc degeneration. In my hands, in my experience, it's much more better, it's much more safe to go in the disc, because you follow the track of the disc herniation, you remove the disc itself. You can accelerate, but you have the disc herniation because it is degenerated.
Yes, of course.
Yeah, that's a problem. Otherwise, you wouldn't have a disc herniation.
Perfect.
And I tried to do the Lloyd technique to stay at the annulus, to move into the foramen. And for me, it was much more difficult to make identification of exciting nerve root. And that's crucial in that kind of surgery, because you have to make the identification. And I'm experienced in nearly all kinds of disc of spinal surgery, even deformities and fusion procedures. If you are faced with a problem with a lateral disc herniation, like I did on Friday with the anesthetist who came to me, he got an extraforaminal L3-4. he was so painful. He was crying for help. He said to me, "Come do the operation." And so the impact you have with that surgery is very small, and you get all really big. That makes your reputation. If you do scoliosis surgery or fusion procedures, your patients are still complaining. They have all these problems with the big access and all. But this is the kind of surgery that makes your reputation. You make them pain-free. I could deliver him today, and he was pain-free and without any neurological symptoms. This is what it makes, what spine surgery makes. And this is the only surgery who gives you that big distance from impact to what you get out.
Any other question is a common question for us here in Brazil. When you know when to stop into removing the disc? Is this a regular question for us? When you stop your discectomy?
Well, I started with just having a few bites in the disc. Now I use hooks. I use other dissectors to mobilize all these loosening fragments in the disc to get out as much as I can. I want to have all the loosening disc, and then I use a radio frequency. I shrink, I coagulate. This is all to avoid a recurrence. This is most time of the surgery. 20 minutes takes me to decompress or to make a central removal of all the loosening fragments. This is what I learned by doing years by years.
Thank you very much.
Oscar,
Facundo quer fazer. Facundo me perguntou no privado, ele gostaria de fazer uma pergunta pro professor.
It's more a comment, but a question. Actually, it's a little experience of what we have here in Argentina with the beginnings of the endoscopic technique, and this question about general anesthesia and local sedation. Here, some groups that had started to do endoscopy saw the local sedation technique as an advertised for surgery, as a marketing strategic for maybe push the patients to choose the endoscopic surgery. And when we were starting to do the surgery, we just say, well, what the hell? We're going to let the patient decide what they want, if they want to do general or if they want to do local, because we think and used to think as you that the general anesthesia is better for us, better for the patient. And it was a really funny response that we had, because I think only 2 or 3 patients choose to do the sedation and the local technique of anesthesia. So every patient was choosing the general anesthesia, and the answer that I got was, I am choosing the general anesthesia because I don't want any more pain. I don't want to feel any more pain. And I know that the inexperienced hands, the pain that you get in the local sedation is minimum, but you had to tell the patient that he's going to be your warning when you are reaching to the nerve root, and you have to teach the patient that if you feel pain, just let me know. And that phrase was too much for them. They said, okay, I don't want to feel any pain, just put me to sleep. I want to wake up in the bed and not have no pain or hernia. So I don't know if it was the same thing to you in Brazil, in Germany. I don't know if the patient had the chance to choose between 2 techniques, or you just used to do only one technique.
Yeah. Hi, how are you?
I'm fine, thank you. Nice to see you.
You have to go to Brazil with us.
Yes, I have to. Next year, perhaps.
Yeah, after COVID.
Have fun. Bye.
Bye-bye.
I want to give a comment on that, because that's the same experience we had in Germany. So most of the patients says to me, but you don't do it in local. I want to sleep. Yeah, that's wish of the patients to have it in general anesthesia. I think it's just a marketing trick to say you can do it in local. I don't know. Most of them want to sleep in Germany too.
Mosca, we need your final considerations because we have more.
Yes, yes. Les Luebers needs to sleep. Yeah.
It's very interesting. So we are talking about wine and endoscopy
all the night.
For
Tom. Yes, okay. Thomas, thank you very much. Thank you, accepted our invite to you, and it's a pleasure to meet you and to know you. You are a great surgeon. Is an example for us here in Brazil. Is a different techniques is need. We need the different techniques to improve our surgery. We don't have one technique to do our surgery. We need to see and choice your technique. Thank you for your time. Thank you for patience with us with a terrible English, but was so good have you here with us. Thank you, Marcos. Thank you, other colleagues. Thank you very much. Good night.
Thank you, and good night to Brazil.
Davi, your final considerations, please.
So I would like to congratulate Thomas for his presentation. It was great. Both of them regarding the German wine, the German white wine, is one of the best I've ever tried, the German white. And to share with us his experience. He is maybe one of the most experienced endoscopic surgeons in the world, and it's a pleasure to have him with us here this afternoon.
Thomas.
Thank you, Thomas.
Thomas, your final considerations for us, please.
Well, I know what happens in Brazil right now, and what I've seen the last years is that there is a big tendency that you move more and more from micro to endoscopical surgery. And what I've seen is that that in Brazil that you are really motivated to improve the technique, to share all these experience, to have different points of views. But I'm sure that Brazil is one of the biggest countries in the world dealing with endoscopic surgery, and I started to try it, to learn a little bit about Brazil and to teach a little bit by philosophy, and make me very proud to see how it goes on. Not even with my technique or with Stort or with Joymax or whatever, Wolf, but I see that the Brazilian colleagues and doctors are doing a very, very, very good job, and I hope that we will have many other opportunities to have congresses, meetings, and to discuss our results, and this will be the future, I'm sure.
Okay, Thomas. So thank you for everybody to listen us, to watching us, and I want to thank you, Thomas, to be my mentor, and Davi to be my mentor too. And we are ending the webinar, and let's try to do the endoscopic surgery. I drank a bottle, a half of wine, so it's impossible to talk anything at now. Okay, thank you for everybody. Bye bye.
Thank you very much.
Thank you, Mosca, Rodolfo, Facundo. Thank you. Bye bye.
Thank you so much.
Thank you all. Thank you. Take care.
Bye.